Dr. Sachs is the Associate Clinical Professor in Psychiatry at Harvard Medical School and the founding director of the Bipolar Clinic and Research Program at Massachusetts General Hospital, where he's been in clinical practice since 1990. He's conducted numerous clinical trials of new medications and has authored more than 200 peer-reviewed publications, including several review articles that focus on optimizing treatment outcomes to meet patients' individual needs. Dr. Sachs serves on DBSA's Board of Directors and is co-chair of DBSA's Scientific Advisory Board. He's a distinguished fellow of the American Psychiatric Association and is recognized as a top doctor by U.S. News and World Report. Dr. Sachs will present an end user's perspective on the development of drugs for depression.
Thank you very much. I'm not sure who wrote that, but I think it might have been my mother. So my task today, following up on Mitch's excellent opening, is to add this perspective as an end user. When I say end user, of course, I'm predominantly referring to the patient perspective. But I want you to understand it's also my perspective as a clinician. When I sit alone in a room with a patient and I have to answer questions and determine what's the next step in treatment, and I am looking for guidance, and I hope we'll have better guidance in the future. But I want to give you a sense of the end user perspective from where we are now. And a few points just to introduce the idea all of this is going to be reviewed for you, but depression has a staggering impact. And we're all aware of the urgent need for better treatments. And notice it doesn't just say more treatments, but better treatments. We would all like to have better treatments. We want to be measuring outcomes not because they're easy, but because they're meaningful. And of course, the reason we're all in the room today is to establish this collaboration going forward with all the stakeholders. And unfortunately, the patient voice has been the softest in the room, if it's present at all, and we'd like to see that change. So let me expand on those points a little bit. This is from Musavi, and you're looking at health scores. And you can see if you have no chronic condition, maybe the average is pretty good, but it starts to dip down with a lot of common chronic conditions. If you add depression to those, you can see that they are all substantially reduced. But if you were to look at the impact of having any two of those chronic conditions, you can see that there's a huge drop-off when depression is part of it. So depression is not a thing apart. It is quite common across disease states. It's not this purebred clinical entity that we see all by itself. It's almost always keeping company with other common conditions. And we're all familiar with the FDA's roadmap. And to add an end user perspective, you can see how for each of the three panels here, we might add a few things. To add to the understanding of the disease, the frightening perspective of knowing the recurrence and relapse rates associated with depression. To look at data that would include the past treatment history for patients. Some of these things are relatively easy to come by, but you won't find them in the literature. To look at the risk-benefit ratios, not just by themselves, but how they actually impact the way patients and caregivers perceive the benefits of their treatment. And of course, we have a lot of emphasis on symptoms and illness, but we're also very interested in what the well periods are like. Are patients able to thrive? Do we get full life back? And one of the other points that is of great concern to us is when we look in the literature and we see the pivotal trials reported, we see all these great results, the question is, how representative are those results to the patient we see? And Mitch made that point. Often the data does not generalize to the treatment-seeking population. This is a huge problem. Mitch also mentioned developing new and perhaps better clinical outcome assessment measures. That would be great. We have some. They all need some work. So Here's a list of common questions that I get from patients. Obviously, what's the best treatment for me? What drug is likely to get me back to normal, like fast? That's a very good question we don't know the answer to. If I didn't get better taking the first drug, call it drug X, what's the chances the drug Y will work for me? And we actually don't have any meaningful data about that. Will continuing the medication that got me well keep me well? What would happen if I kept taking it? What would happen if I stopped taking it? And are there things that patients can do that will increase the likelihood of their response? We actually have precious little data for any of these. Now, this statement I used to think came from Paul Lieber. I think I first heard it at an early NCDU meeting in Key Biscayne, but it turns out it's from Edward Deming. And in God we trust, all others must bring data. And at DBSA, and I know increasingly all across advocacy, we embrace this idea of bringing data to the table. And we'll present a little bit of survey results. I have a quick cross-section of some of the results. The survey I'm going to tell you about today assessed wellness strategies and the perceived benefit from the treatments that patients get. So here's some good and bad news. Good news is patients do a lot of things to try to get better, not just one at a time, but they will often combine medication, wellness strategies, and various forms of psychotherapy, peer groups, et cetera. Unfortunately, the satisfaction is not great. You see that the not effective tends to be about a quarter to a third of patients with unipolar and bipolar group, and the completely effective is under 30% in both groups. So we have a lot of unmet need. Now, what happens when patients get these treatments? They are continuously searching for both efficacy and tolerability, but you can see they seldom find it. Didn't feel it was working sufficiently. That's 2/3 or so of patients. About half to 2/3 of patients stop for tolerability reasons. So very common condition. Half the patients are looking for a new treatment every 3 months. Now, when we look to the literature to say which should that new treatment be, we get back to this representativeness issue. And this is from STAR-D. You can see if you divided the sample based on those who would have gotten into a typical efficacy trial versus those who would not, about 80% of the patients in STAR-D would never have made it into a trial that would get FDA review. And these are the kinds of patients that are out there seeking treatment. And you wonder, does this matter for outcome? So you can see in the blue line, that's the efficacy sample. And getting higher up there means that more people are getting better. Being lower down, like where the red line is, they're not. So a lot of the patients who don't make it in but require treatment, they're not getting as good an outcome even as we would expect from standard clinical trials. This is another view of a similar kind of issue, and it gets back to that new self-report measure that Mitch mentioned in his talk. Here we're talking about the QIDS, another kind of outcome measure, and there's a clinician-reported version of it and a self-report version. So the top blue line is where it starts out, I guess, in the middle is the clinician version, and then you see that middle line, that's the patient-reported version. And you can see that even when the severity measure is the same, there's a gap here. There are a number of people who the clinicians are thinking are getting better, where the patients do not perceive themselves to get better. We need to account for this, particularly as you can see here, the bigger that gap is, the worse the outcome is overall, and the more and more we have people who are getting treatments that they perceive as completely ineffective. One of the experience for me when I was principal investigator for STEP-BD that was really instructive, the NIH and its wisdom required us to conduct focus groups and ask clinicians, patients, and family members about the outcome measures we were going to use. And this idea of durable recovery, which in STEP-BD required 8 consecutive weeks you know that no clinical trial has ever used that. All the clinicians, we we asked thought that that was much too stringent, and every patient group and every family group said that that is much too short to be meaningful. Now, from our point of view, that meant we got it exactly right. I think outside the room, it means we really got it exactly wrong. So we would like to see the bar raised. We would like to see the roadmap include these items. We would want to all encourage better treatment. And I think a big part of that is including patient stakeholders in the process. That's why I'm glad you're all here. All of you in the room have a role in this. We really want to see some meaningful evidence as quickly as possible. Let's build on what's working and continue this collaboration. Thank you very much.
Okay, thank you very much, Dr.